Sure. So naltrexone has also been around for decades in various forms for different indications. For instance, it was approved in 1984, I think it was, but a couple decades ago, for the treatment of patients with alcohol use disorders. Most recently in 2010, so just 5-6 years ago, it was FDA approved in the monthly injection form, which is currently branded as Vivitrol in the United States. The monthly injection was approved for the prevention of relapse for patients with opioid use disorders. And the idea with naltrexone is that it's a blocker. Some people confuse it, even physicians sometimes confuse it with naloxone, which is Narcan. And there's much more press, if anything, that's covered the potential role of naloxone or Narcan for reversing overdoses to try to prevent fatal overdoses. Naltrexone is very similar to naloxone, except it lasts much longer. So the pill form of naltrexone lasts for about a day, and the injection was designed to last for a month. And the idea with naltrexone, similar to naloxone for reversing overdoses, naltrexone completely blocks the activity of the opioid receptors. And what that means is that if someone has naltrexone in their system, they have that month of the active medication from the injection. Even if someone were to use heroin or take a Percocet, take an oxycodone, the extended release form, the monthly injection of naltrexone will completely block the action of opioids at the opioid receptor.
So if I was on naltrexone and I took, say, Percocet, I actually wouldn't have the experience or normal feeling that I would if I was not on the naltrexone?
In general, most people will say they don't feel anything at all.
Okay.
And that's part of the therapeutic benefit, is that patients who are used to paying $10 to get a certain kind of pill, to take it to get a certain kind of effect, are all of a sudden wasting their $10 and not feeling the effects they're expecting.
Am I at risk for even overdose to say, hey, I'm going to take more Percocet because I'm not feeling it?
To try to override the blockade.
Right.
That was a big concern. And before, for any medication to be FDA approved, not only does it need to be shown to have efficacy for a given indication, but it also has to be shown to be safe. So before naltrexone was ever approved for the prevention of relapse in opioid use disorders, it had to go through safety trials. And it was not shown to increase the risk of death. And we've had studies over the last 5 years looking, several months, even several years of follow-up. And to date, there are no large studies that have suggested an increase in the risk of mortality. So there's this, what we would think of as a theoretical concern, that if someone's blocked and they try to override it by taking more and more and more Percocet, more and more heroin, something like that they would have an overdose fatality. But so far, we have no evidence to show that that's actually happening with Vivitrol. On the flip side, we know that anyone who's on Vivitrol uses opioids at drastically lower rates, which confers a lot of protection in terms of mortality risk.
So this sounds like a great medication that not only treats opiates, but also has evidence-based to treat alcohol use. Why are we not using it more?
So if you look around the country, there are thought to be about 2.5 million people who have opioid use disorders, about 500,000 addicted to heroin, and almost 2 million addicted to prescription, like pain medications, the pill forms of opioids. And maybe, it depends on which study or how you look at it, but maybe 10 to 40% of those people get treatment in a given year. And only a fraction of the patients who get treatment receive evidence-based medications, like methadone, buprenorphine, or naltrexone. So out of the 2.4 million people in the country who have an opioid use disorder, we have maybe 300, 400,000 people on methadone in a given year. Through the drug treatment system, the publicly funded drug treatment system, there are only about 40,000 people on buprenorphine. And the most recent data from a couple years ago suggests that maybe 5,000, 10,000 people receive naltrexone in the monthly injection form.
I mean, that sounds severely underutilized.
So the numbers suggest in the drug treatment system that about 10% of people who need to be on MAT are receiving MAT. for opioid use disorder. So the great majority of patients who would benefit from the treatment currently can't access it or get into treatment programs that disallow the use of MAT.
Do you think that most of the people that are in treatment that aren't getting it could benefit from MAT?
So the evidence definitely suggests that for patients with substance use disorders where opioids are the drug of choice, that MAT is the gold standard treatment in combination with psychosocial and behavioral treatment. So the idea is that because the risk of overdose death for patients who have injection histories, the risk of contracting hepatitis C, HIV/AIDS are so high that all patients should be offered MAT. And ideally, all patients would have the option of any of the three modalities because there are pros and cons to each one. And depending on the patient and depending on what phase of treatment the patient's in, one modality might be more effective than the others.
Great, thank you.